Bismillahirrahmanirrahim. Today we will try to understand, to speak, to have a conversation, not just Dr. Daniel speaking about ventilator-associated pneumonia, VAP. Any idea? What is it? Just pay attention to the name. Ventilator-associated pneumonia. What can you say about that? What is it? What's it about? That's pneumonia acquired on ventilator. Any other idea? What can you see here in this case? Anyone? Raising the hand. Anyone has any experience on any form in any X-ray? Pneumonia, good. You can see it. Whole face, body capacities.
This tube, huh?
First one, do you concentrate on the technique? Is it a good technique or not? How can I know if it's a good technique or not? That pneumonia associated or acquired on patient on ventilator, but patient can go ER with respiratory failure, with breathless, bronchospasm, shortness of breath, nasal flooding, intercostal pulling. In the X-ray, you can see this same X-ray at the moment of admission and at the same moment of intubation. Can I speak? Can I say, is this a ventilator-associated pneumonia? It is not, right? So, most of the definitions speak about the ventilator pneumonia, and that one that appears as a combination of clinical, radiological, and microbiological components, but after 48 hours after intubation, 2 days after intubation. Because ventilator-associated pneumonia is directly related with high mortality, morbidity, increase the hospital budgets because of the high cost of treatment, because it increases the state of the patients in the ICU in the hospital. For example, ventilator-associated pneumonia increases the cost for every patient about $40,000 to $50,000 per day. So that is why it's so important to speak, to understand measures of prevention and anything management of this kind of condition. Over 90% of the hospital-acquired pneumonia, 90%, almost all the acquired pneumonias have been associated with mechanical ventilation. About 50% of these ones occurs in the first 4 days. And why is so important to classify them? Ventilator-associated pneumonia is a combination of these factors: radiological, microbiological, and clinical. In patients receiving mechanical ventilation at least 48 hours. By clinical evaluation, clinical examination, how can I know that the patient has pneumonia? Or unless imagine that the patient has any pneumonia. Any idea what happens with the patient with pneumonia? For example, don't think about ventilator-associated. Any patient with pneumonia, what can appear?
Fever,
Desaturation, fever,
crackles, diminished sounds,
diminished thoracic sounds. Many times we don't see all these clinical features in the same patient because we study the disease, the condition, but we evaluate patients. And remember that in medicine, 2 plus 2 is not 4. In medicine, we have to evaluate patient by patient individually. But we can find many of these clinical features. For example, fever, shortness of breath. We can, on auscultation, we can get palpitations, breaths. We can hear that respiratory sounds are diminished. Many times bronchospasm appears like wheezing, intercostal pulling in the most severe cases. And we have to be able and very accurate and identify if it's a pneumonia or any other condition. Not only by clinical physical examination, only by asking the previous history of the patient. Then of course, if we have X-ray, if we have CT, alhamdulillah, much better and easier to identify the condition.